This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you who are new, I'm a Med-Peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh. We have been coming to you for a while now, since October of 2016. So this is now going into our 6th and to our 7th year of this podcast, doing continuing medical education, covering topics in pediatric hospital medicine, going through initially the guidelines or the American Board of Pediatric Content Specifications. But now we have an exciting episode today. As the holiday season is rolling around, nothing says holiday like hyperbilirubinemia. The new guidelines have been out this year, and we have decided to cover them. And I'm sorry we've taken so long. You can blame me, and I am sorry for it. But we want to cover the new hyperbilirubinemia guidelines. Before we get into that, I do want to say to everyone listening, if you're working right now, you're working extremely hard. I know I'm working extremely hard, long hours, a higher volume of patients than I've ever seen in my career. I know we're all with you. We're all there for each other. I don't have any great inspirational words, except I'm thinking of all of you. We're all thinking of all of you. We will get through this together. You can do this. Please take care of yourself and take time out for yourself if you need it. Now, back to the guidelines here. We really wanted to cover these hyperbilirubinemia guidelines well, and we were very fortunate to get one of the authors of the guideline here on the show to help us go through them. So let me introduce, who's also a pediatric hospitalist herself. Our expert guest for today is Dr. Alison Volpe Holmes. Dr. Alison Volpe Holmes currently serves as Associate Dean for Student Affairs at Geisel School of Medicine, an Associate Professor of Pediatrics of the Dartmouth Institute. Dr. Holmes attended Haverford College, medical school at Stanford, completed pediatric residency at the University of North Carolina, Chapel Hill, did a fellowship in general academic pediatrics, and an MPH at the University of Rochester. Her teaching interests include medical student career selection and advising, promotion of supportive and inclusive learning environments, and medical student and resident education and clinical quality improvement in high-value healthcare. Her research interests focus on clinical quality improvement, particularly in the newborn nursery, in areas such as breastfeeding, jaundice, circumcision, and newborn opioid dependence. Dr. Holmes is a past board member of the Academic Pediatric Association and currently serves on the General Pediatrics Examination Committee of the American Board of Pediatrics. And for those of you listening, I botched this up. I don't know why I'm having trouble reading today. But Dr. Holmes, thank you for joining us on the show. We really appreciate it.
Great. Thank you so much. I'm really glad to be here.
All right. So, Alison, this is a CME podcast from the University of Pittsburgh. So thank you, University of Pittsburgh. So we do have to do our disclosure statements. I will go first and kick it out to you. I do have to disclose that I am on a board for advisory board for Sanofi for the meningococcal vaccine and immunocompromised patients. You're up.
So I'm Alison Holmes. I don't have any conflicts of interest to disclose related to this presentation. I am on the examination committee for general pediatrics for the Board of Pediatrics.
Now, Alison, this is great. We have been waiting, and I have to tell you, I've had conversations with people where we're talking about hyperbilirubinemia or talking about the podcast, and they say, we can't wait for the new guidelines to come out to cover them. And so thank you for being here.
Glad to be here, and it was great to be on the guideline committee.
Let's start with what I always start, which is let's read the title. We'll go through the authors, and then we'll dive right in. So this is from the American Academy of Pediatrics, August 5th, 2022, Clinical Practice Guideline Revision, Management of Hyperbilirubinemia in a Newborn Infant, 35 or more weeks of gestation. The first few authors are Dr. Alex Kemper, Dr. Thomas Newman, Dr. Jonathan Slaughter, Dr. Jeffrey Masais, Dr. John Watchko here from Pittsburgh, et al., including Dr. Alison Volpe Holmes, who's with us. So, Alison, my first question to you is, this took 8 years in the making. Why did it take so long?
It did take a really long time. I think one of the hardest things about this guideline in particular is that it's really hard to have high quality evidence for a lot of the guidelines. Particularly, it's hard to come up with the appropriate treatment, hour-specific treatment nomograms. And the reason it's so difficult is that the outcome that we're trying to avoid is so exceedingly rare. So when we're talking about what we're trying to avoid, that is, of course, chronic bilirubin encephalopathy, which is the clinical entity that is typically called kernicterus. Kernicterus is a pathologic term for the staining of the basal ganglia. The thing is, in North America, and this is a US-specific guideline, our rates of chronic bilirubin encephalopathy are on the order of 1 in 100,000 to 1 in 150,000. So when you're building treatment nomograms, that's not your outcome. And so we're always using basically proxy measures for the outcome. And that's why it can be so hard to come to consensus on what an appropriate treatment threshold is, both for phototherapy, but also for exchange transfusion.
Can I ask, what would be a proxy measure for kernicterus?
So the way that nobody has done it for kernicterus, in terms of the phototherapy nomogram, people have generally thought about making a phototherapy nomogram such that one can prevent from getting to an exchange transfusion level. And that's typically how the phototherapy nomograms have been constructed. Sometimes people have picked a number. So we'd like to construct our treatment nomograms such that we see the minimum number of infants coming back with bilirubins over 25 or bilirubins over 30. That's another way that you could decide to construct your nomograms.
I see. Okay, so you construct it in a way to have people coming back with lower and lower bilirubins than you would be worried about, which makes sense. Now, to get into the guideline a bit, I really like how it started. We already talked about kernicterus, but to read the definition specifically from it, it's a permanent disabling neurologic condition characterized by some or all of the following: chorioathetoid cerebral palsy, upward gaze paralysis, enamel dysplasia of deciduous teeth, sensory neural hearing loss or auditory neuropathy, or dyssynchrony spectrum disorder, and characteristic findings on the brain MRI. And that's what we are hoping to avoid is the point of this guideline.
And it's a terrible disease. So whenever I'm actually, giving a talk where we have slides and visuals, one of the first things I do anytime I talk about jaundice is show some videos of children who will suffer lifelong from chronic bilirubin encephalopathy. Because yes, it is a 1 in 100,000 kind of disease, but it is not a disease that we ever want anyone to have.
I think that's a great idea because I have to tell you, I'm trying to sit here and think if I've ever seen it in my career, and I don't think I have. And I'm not a neonatologist, so perhaps if I was, I would, or I'm not even what you'd call a newborn hospitalist. I'm not, but I can't remember ever seeing it. So I don't know that it's something people see very often. So videos are helpful, which is not great in a podcast setting. But in general, I think that's very helpful.
Yeah, it is helpful. And when I ask an audience of even, 100 or a couple hundred people to, raise hands who has seen a child with this condition, I usually only get a couple of hands.
Yeah. So if people are wondering who was on the committee, what I have from the guidelines are there were neonatologists, hospitalists, primary care pediatricians, nurse and breastfeeding experts, and some members also had special expertise in neonatal hyperbilirubinemia.
We did, yes. We also had a hematologist. We had some informatics specialists. We had an epidemiologist and a family physician and a nurse practitioner. So it was a pretty full committee.
Now, one of the initial things that were brought up is it was interesting because they brought up that after the recommendations were made, I want to say in 2009, a commentary which made clarifications for hyperbilirubinemia risk factors, that the incidence of hazardous hyperbilirubinemia defined as total serum bili greater or equal to 30 milligrams per deciliter decreased in at least 3 large U.S. health systems. And I bring that up to show that these guidelines can be very helpful. Even the additions that are made, that they can really This is, to me, showing that it can really help patients in the field, which makes sense.
Yeah, that's true. And the biggest change, the full guideline, the old one, was 2004. The 2009 update made official the recommendation for universal pre-discharge bilirubin measurement after the newborn hospitalization. And that's what has been found to be associated with the decreased risk of hazardous hyperbilirubinemia, whether you define that as over 25 or over 30. There are papers that show that the universal discharge measurement did have that effect. And when that recommendation originally came out, it was rather controversial because there actually wasn't much evidence to support it at the time. But we were able to give it an evidence grade of C in this guideline and to continue that recommendation.
Oh, that's great. Now, it starts out with prevention in hyperbilirubemia, and the review here says that prevention begins in pregnancy by recognizing and treating women who are at risk for developing antibodies to red cell antigens, which can lead to hemolytic diseases of the newborn, like isoimmune hemolytic disease. And it goes into the first key action statements here. If maternal antibody screen is positive or unknown because mom did not have prenatal antibody screening, the infant should have a direct antiglobin, DAT, direct antibody test, and the infant's blood type should be determined ASAP, either using cord blood or peripheral blood. And it reminds us that the DAT helps to identify infants at risk for hyperbilirubinemia attributable to hemolysis. So mothers who receive the Rh immunoglobulin can have a positive antibody screen for anti-RHD, and Rh immunoglobulin can cause a positive DAT, but generally no hemolysis. So if mother got the RHIG, the Rh immunoglobulin, you can get both positive, but there is no hemolysis. And so that's the first key action statement. Really seems to be talking about in pregnancy, this is how you can prevent it before the baby's ever born.
Yeah, and figure 1 in the guideline, that's a new figure for this guideline. It talks about how to review and interpret maternal antibody testing, and I think it's helpful. There were a number of us on the committee, myself included, who some of the, I guess I would say, the most important near misses we'd seen had been in newborn nursery cases where when the baby was admitted, it just seemed like the person reviewing the prenatal labs potentially glossed over a positive antibody result that wasn't just due to RhoGAM administration. And so we're really trying to point people to make sure that they're reviewing those results and seeing if there are any important antibodies to things like minor red cell antigens.
Oh, that's great to know. I like hearing about like what goes into the thought process besides pointing some things out, because the next section I thought was a really nice review of breastfeeding and breast milk jaundice. Although, so I'll read it. So you talk here about how exclusive breastfeeding and hyperbilirubinemia are strongly linked, and you discuss breastfeeding jaundice, which is really inadequate milk intake, and they feel that you feel the name is more aptly titled suboptimal intake hyperbilirubinemia, which I'm not sure will catch on, but it may. They also said that breastfeeding fewer than 8 times per day has been associated with increased total serum bili concentrations, which I didn't know. Low milk and low caloric intake contribute to decreased stool frequency, and that causes increased enterohepatic circulation of bilirubin. And then you go into breast milk jaundice, which is a prolonged unconjugated hyperbilirubinemia, which can last up to 3 months and is almost always non-pathologic and not associated with direct or conjugated hyperbilirubinemia. I really felt that was one of the nicer reviews I've ever read about the two topics.
Yeah, the way I've taught it to the residents for years, and I'll try to use the new term here, although I might modify it slightly. What I would typically say is breastfeeding jaundice is from a lack of feeding, and breast milk jaundice is because there's something in the milk. So the feeding one, the suboptimal intake jaundice, as we'll call it, and the thought with there is that it's not breastfeeding per se that's causing that type of jaundice. It's simply a starvation jaundice, and if you had a formula-fed baby who wasn't taking in adequate amounts of formula, they would have the same problem. So it's kind of separating out those two different causes, because if you have suboptimal intake jaundice, the main treatment is feeding.
Yeah, and you go into it later, but since we're talking about it, we can bring it up now. The breastfeeding jaundice or suboptimal intake hyperbilirubinemia, later key, well, we'll get to it. It's in a later key action statement, but we'll keep chugging along here. The second key action statement is don't supplement water or dextrose water orally to prevent hyperbilirubinemia or decrease concentrations, which I think is a good one to bring up. I'm a big fan of that.
That was a repeat from the earlier guideline from 18 years ago. It's an unchanged statement.
And I still hear it from families, so I think it's important to keep it going. And it's still very true. Now, this next section on risk factors for hyperbilirubinemia, I have to be honest, initially when I read it, I was like, oh, I'll probably skip that before I read it because it was a lot to cover. This is a big guideline. And it's just stuff, people who work in this know this, but some things were brought up that I loved and I don't think I knew, and specifically exclusively talked a lot about G6PD. And just to recap, G6PD screening is not routinely performed in a newborn screen nationally. I did check in Pennsylvania, it is done, but G6PD is an X-linked recessive enzymopathy. I didn't know or forgot that now it's recognized as one of the most important causes of hazardous hyperbilirubinemia, when that's a direct quote, leading to kernicterus in the U.S. and across the world. And when it says most important, I'm reading that as one of the most prevalent. Mm-hmm. Is that a fair thing to do?
It is, because most of the other things that might cause hazardous hyperbilirubinemia are fairly predictable, or we would have laboratory information indicating that they're there. The issue with G6PD, as you stated, is that we don't routinely screen for it. Even when we do, the result isn't back. A newborn screen isn't back within time for when it's going to make a difference. The screens done in the newborn period have problems with false negativity anyway. And the problem is with G6PD, the baby can not have much jaundice in the initial birth hospitalization and then come back extremely jaundiced a few days later.
That's it. And you did drive home the point that this condition is prevalent in peoples from sub-Saharan Africa, Middle East, like my family, Mediterranean, Arabian Peninsula, and Southeast Asia, and specifically for the U.S., in 13% of African-American males in the U.S. and 4% of African-American females in the U.S. have G6PD deficiency, which, it's helpful to know because if this is one of the most important or most prevalent causes of kernicterus, we've already talked about how that's something we genuinely want to avoid. This is a population we should be a bit more cautious to be certain that everything is okay. So I find it to be very helpful.
I think it's helpful. I think as an author, the author group would say that we should be concerned about this disease in all babies because there is that significant portion of Mediterranean and Southern Europe where you wouldn't necessarily have any kind of a visual cue that the child would be at higher risk. So basically, one of the main things the guideline is saying, both with that figure 1 about the maternal antibody and with this emphasis on G6PD deficiency, is just to be really aware of situations where you think hemolysis might be occurring.
And it goes in even further, saying severe hyperbilia or atypical hyperbilia in a formula-fed infant or late-onset jaundice that's high should perk up your antenna a little bit. I think that's a great point you brought up. All right, so the third key action statement is one I'm not sure there's going to be much debate over. It's that use total serum bili as a definitive test to guide phototherapy and escalation of care decisions, which we'll get to towards the end, which I think is that's a carryover from the previous one and still makes a lot of sense.
Yes, it's just a reminder that although transcutaneous bilirubinometry is a really helpful tool, it's nice to have point-of-care testing. It's non-invasive. It's less expensive. That it's also not completely accurate. And so it can be used for screening, but decision-making should always be done with a serum sample.
And now you bring up, and just for our listeners, in medical education podcasting, one of the little tricks is if there's a point you really want your listeners to know, you repeat the point. And that's just a part of any type of education using a visual or auditory format where you're not live. One of the ones we're going to drill home today, because it's all over the guidelines, is hyperbilirubinemia neurotoxicity risk factors. Now, this is brought up here, and it says the presence of these hyperbilirubinemia neurotoxicity risk factors lower the threshold for treatment with phototherapy and the level at which care should be escalated. Now, just to recap what they are, the risk factors are, first, gestational age less than 38 weeks. Second, albumin less than 3 grams per deciliter. Third, isoimmune hemolytic disease or other hemolytic condition. Sepsis or significant clinical instability in the last 24 hours. I got to say, one of the things I loved is that you didn't just say it, you guys went into it and described why, which always helps me. So you discussed that an albumin less than 3 grams per deciliter, as an example, is a risk factor because low serum albumin potentially increases the availability of unbound bilirubin because bilirubin binds to albumin. And then exactly what you just said, how the visual estimates of total serum bili, we'll get to that, but the visual estimates aren't great, except if a child has absolutely no jaundice on exam, then a total serum bili greater than or equal to 12 is unlikely. But I liked how you kind of went into and described why the neurotoxicity risk factors are important.
Yeah, I think if you're thinking from a newborn nursery perspective, which and even I think from a general hospital medicine perspective, really the most important ones on this table are going to be your gestational age and the isoimmune hemolytic disease or other hemolytic diseases. The other issues are frequently more neonatology issues than they would be for those of us in general pediatrics or hospital medicine. The albumin comes up a lot. If I'm having atypical jaundice, if I'm starting phototherapy, should I check an albumin? Congenital nephrotic syndrome is pretty rare. That would be the main cause of a low albumin like that. But it is important because, as you said, that unbound bilirubin can cross the blood-brain barrier. That's what's going to cause the basal ganglia staining. And so you can have effects on the basal ganglia at lower total serum bilirubin levels.
That's very helpful. Now, getting into the next key action statement, all infants should be visually assessed for jaundice at least every 12 hours following delivery until discharge. Total serum bili or transcutaneous bili should be measured as soon as possible for infants noted to be jaundiced less than 24 hours after birth. And it goes into when there is jaundice, clinically significant jaundice before 24 hours of age, the concern should be a hemolytic process. And the guideline over and over stresses the importance of identifying early onset jaundice due to the concern for significant hemolysis. That's a point that's brought up over and over again.
Yes. If I'm giving a talk on jaundice, we hammer this home as many times as we can. Hemolysis is really the key to hazardous hyperbilirubinemia, whether that be hemolysis that is present from delivery, so therefore noting that jaundice under 24 hours is unusual, or a later onset jaundice like one has in glucose 6-phosphate deficiency.
Okay. So the fifth key action statement is that total serum bili or transcutaneous bili should be measured between 24 and 48 hours after birth or before discharge if that occurs earlier. And infants born at home, it talks about, also should have bilirubin testing around the same time, between 24 and 48 hours after birth. That's pretty straightforward.
So the key action statement 5 is emphasizing a recommendation originally made in the 2009 update. Initially, that was rather controversial to do this pre-discharge bilirubin test, but now we have evidence showing that it decreases babies coming back with hazardous hyperbilirubinemia later.
And then the sixth key action statement is total serum bili should be measured if the transcutaneous bili exceeds or is within 3 milligrams per deciliter of the phototherapy treatment threshold, or if the transcutaneous bili is greater than or equal to 15 milligrams per deciliter. And that's a grade C evidence-based recommendation. I think that's a carryover from last one, correct?
It actually is a little bit different because there have been a couple really good papers in the interim looking at paired transcutaneous and serum bilirubin measurements. There was a big paper published from the APA Born Network about 6 or 7 years ago where they did a multi-center study and looked at about 8,000 paired measurements. And so we were able to make this recommendation with better evidence at this point, showing that it's really at around 15 where you start to lose the concordance. And then the within 3 is really because, if you're going to make a treatment decision, because you're near the phototherapy threshold, you want to make sure you have a serum measurement.
It's helpful because this is more of what for me. So again, for what I do in Pittsburgh, I am not a newborn hospitalist. I'm mostly a hospitalist in a freestanding children's hospital, and we get kids after the newborn period. So I don't typically do the newborn part of it, but it's really nice to know when our outpatient colleagues or our newborn colleagues, when somebody is admitting a patient, what their guide. This is very helpful. And I love the background you're giving me. Thank you. So the next statement, if more than one transcutaneous bili or total serum bili measure is available, the rate of increase may be used to ID infants with a higher risk of subsequent hyperbilirubinemia. A rapid rate of increase of greater than 0.3 or equal to 0.3 milligrams per deciliter per hour in the first 24 hours, or greater than or equal to 0.2 milligrams per deciliter per hour thereafter is exceptional and suggests hemolysis. In this case, perform a DAT if not previously done. And this is evidence grade D. This I found extremely helpful.
Yeah, we actually had a good bit of debate about whether we should include rate of rise in the guideline or not. And we decided to include it with starting this statement with that term is available. We didn't want people to think that every single baby needed to have 2 measurements and a rate of rise calculated. It's really just if you have them, this is something you could look at. And then these would be the parameters that might suggest hemolysis.
I love it. I mean, having that, you're right. You don't always need 2. For what I do, I end up typically having more than 1. And knowing these numbers for me is extremely helpful. And then for the 8th key action statement, if appropriate follow-up cannot be arranged for an infant recommended to have an outpatient follow-up bilirubin measure, discharge may be delayed. And this is something I think we do, but it's nice to see it as a formal recommendation.
Yeah, there's a chart we'll get to later that also talks about appropriate follow-up. One of the things that the guideline committee was tasked with was being more explicit about, 1, when to follow up babies after newborn discharge based on their discharge bilirubin number, and 2, when to follow up babies after they've been treated with phototherapy.
Yes, that's very helpful. All right, so the 9th one, for breastfed infants who are still jaundiced at 3 to 4 weeks of age and for formula-fed infants who are still jaundiced at 2 weeks of age, the total and direct bilirubin concentration should be measured to identify possible pathologic cholestasis. And you discuss here that in prolonged jaundice, reviewing a newborn screen is a very good idea because some other conditions tested for, like galactosemia, hypothyroidism, and tyrosinemia, can cause persistent jaundice.
We do, and we just wanted everyone to remember that jaundice need not just be from hemolysis or immaturity of the liver conjugation process. There is, of course, also the rare cholestasis that we know we need to intervene in early. While breast milk jaundice can be normally there for 3, even 4 weeks, if it's really there that long, it's worth checking a direct bilirubin just to make sure that an infant with biliary atresia can be identified within that first month of life. And still have potentially a good outcome from a Kasai procedure.
Yeah, I loved reviewing that. I mean, especially, and then the other conditions as well. Just the more times you read it, as I can't tell you I don't think I've ever seen galactosemia causing prolonged jaundice, but now that I've seen it and read it again, I'll think about it. Now we're going to get into the part I've been waiting for, the treatment of hyperbilirubinemia. So we're going to start with, in the guidelines, you're talking about phototherapy. You discuss how it decreases bilirubin concentrations through photochemical reactions, allow bilirubin to be more easily excreted. And clearly its effectiveness is dependent upon A, how intense the phototherapy is, and then how much of the baby's surface area is exposed. And there is no standard method for delivering phototherapy, and there is substantial variation in phototherapy equipment. Now, that was a direct quote, And the word substantial caught my eye.
Yeah, I mean, there's a big difference between multiple overhead lights placed at an appropriate distance from the baby versus using simply something like a blanket underneath the baby. It's really intensive phototherapy that's recommended once baby's bilirubin is over the new treatment threshold.
And then the intensive phototherapy requires narrow spectrum LED blue light with irradiance. And the general approach is as much of the surface area as possible. The primary goal of phototherapy, which was nice to read, it decreases the likelihood of further increases in the total serum bili concentration that would lead to a need for escalation of care, including exchange transfusion. That's the number one goal, is not to let it go up higher. Mm-hmm. And then the recommended phototherapy thresholds are far below those at which overt bilirubin neurotoxicity or kernicterus occurs, which makes a lot of sense.
Yeah, so people are often surprised to hear that when we look at the more recent large North American studies, the average serum bilirubin in the confirmed cases of kernicterus with subsequent chronic bilirubin encephalopathy are 40. So 40 is the average, and there's some in the high 30s. But our previous treatment thresholds were way, way, way below that. And even our exchange levels were 15 points below where we were really seeing neurologic damage. And so we felt from these larger studies now with cohorts of over 1 million children with good follow-up that we could safely raise these phototherapy thresholds. We also knew that lumping together all the 35 and 0 days all the way up to 37 weeks and 6 days babies was probably inappropriate, and that we didn't need to treat the almost 38-week baby at the same threshold as the just 35-week baby.
Well, that makes a lot of sense. And I didn't know 40 was the number. That's higher than I thought it was going to be.
It's higher than most people think it is, but the really good cohort studies with universal follow-up come from Kaiser Permanente Northern San Francisco, and they've published a lot of papers at this point. So that's where you can see that the rates are, lower than 1 in 100,000. Most of the cases that are in their cohorts are children who have then been determined to have glucose 6-phosphate deficiency on later testing.
That makes a lot of sense. Kaiser does great work. That's wonderful. Thank you. Now, I actually read the accompanying technical point on what I'm about to read. There is some evidence that phototherapy may lead to a small increase in the risk of subsequent childhood epilepsy, but the committee felt, according to this, that the benefit of phototherapy exceeds the small potential risk of epilepsy when the total serum bili is or at above phototherapy threshold. And I went to read this evidence, and it was 2 observational studies. They found a small increase in the risk of epilepsy in males treated with phototherapy. And it went into if the findings are causal, which observation doesn't necessarily mean causal, for approximately each 100 to 250 males treated with phototherapy, one will be diagnosed with epilepsy by 10 years of age. There had to be a lot of debate with even including that in the guidelines. Is that correct?
Yeah. So, these are risk-benefit decisions. And one of the questions I've been getting a lot is, given the Kaiser data, people were surprised we didn't raise the phototherapy thresholds even further. We went up about 2 points at the later part of the curve. We thought maybe too big a change people would be uncomfortable with, and that it would be better to study what this change did. But we were basically trying to balance risks versus benefits. So we did talk about the seizures, but yes, these are observational studies and the risk is relatively small. We also talked about a few cohort studies that have looked at, again, mathematically small but significant increased risks for acute myelogenous leukemia or AML. And then I won't say the more prevalent risks are actually a little bit softer in that when we treat babies unnecessarily with phototherapy, it's pretty stressful for families. And there have been a number of studies showing that when children are treated with phototherapy, their parents perceive them to be ill infants. There's an older paper describing an association of vulnerable child syndrome with phototherapy. In addition, there's a Kaiser study and an older Yale study showing that children who are treated with phototherapy will often come back to the pediatrician more frequently than do other babies.
That's fascinating. Just from the phototherapy, I didn't realize that.
It's really the parents' perception.
Yeah, I didn't. Yeah. Now, the area that I was fascinated by, the next section is exposure to direct sunlight has been shown to decrease total serum bili concentrations, but there are practical difficulties in doing that and avoiding sunburn, which makes it less reliable. And filtered sunlight has been used safely in resource-constrained settings where phototherapy is not readily available. And then you talk about how these guidelines are for the U.S. with the resources we have available. And then I remembered the story of how phototherapy was really discovered. I believe it was nuns at a convent taking care of babies, and they found the ones next to the window did better when they got jaundice. And that was kind of the intro to all this. So it all kind of came together, but I just loved reading that. That was
cool. It was I believe in the 1950s in the United Kingdom, and it wasn't just the babies near the window. What actually happened one day was someone drew a serum bilirubin from a baby who was jaundiced and expected it to be, around a certain number, but accidentally left the tube on the windowsill for a few hours and then ran the sample, and the sample came back much lower. And so that was where they wondered if the fact that it had been left in the sunlight lowered it, and they started looking into it.
That is fascinating. Now, we're only on KAS 10 and we're 40 minutes in.
I don't have anything right after this if you want to keep going.
Oh, okay, good. Thank you. So then the next section goes back into the hyperbiliary neurotoxicity risk factors, which I'm going to quickly reread to drive the point home. Gestational age less than 38 weeks, albumin less than 3 grams per deciliter, isoimmune hemolytic disease, glucose-6-phosphate dehydrogenase deficiency or other hemolytic disease conditions, any sepsis or any significant clinical instability in the previous 24 hours. Now, KS10 I even circled as very hospitalist relevant. Discusses when intensive phototherapy is recommended. And the threshold for phototherapy are based on expert opinion, as we've talked about, and distinguish between infants in whom benefits of phototherapy do or do not exceed its risks. And you discuss here at length clinicians and families may choose to treat at lower levels based on individual circumstances or preferences. There's an example of the option to begin phototherapy at subthreshold levels during a birth hospitalization to reduce the risk of readmission. And I'm assuming this is in here to remind the reader this is a guideline. Please base your decisions on the patient in front of you and the circumstances that they're in.
It is. And there was actually a debate over whether subthreshold phototherapy should be recommended to continue. So that's why it's presented with all those caveats as it is. But yes, that is to remind us that it's a guideline and that we need to use individual situational decision making.
Now, the next one is if an infant gets discharged from the nursery and develops a total serum bili above the phototherapy threshold, treatment with a home LED-based phototherapy device rather than readmission to the hospital is an option, and especially now with hospitals so full, it's very helpful. But infants have to meet the following criteria, and I'm going to go through them somewhat slowly. Gestational age greater than or equal to 38 weeks, greater than or equal to 48 hours old, clinically well with adequate feeding, no known hyperbilirubinemia neurotoxicity risk factors, which we've already talked about, no previous phototherapy, total serum bili concentrations no more than 1 milligram per deciliter above the phototherapy treatment threshold. An LED-based phototherapy device will be available in the home without delay. Total serum bili can be measured daily. And it goes into if any infant has any hyperbiliary neurotoxicity risk factors, they should not get home phototherapy. It's kind of stressed. Mm-hmm. And that you go into how phototherapy can, and you've talked about this already, how it can be less costly at home, less disruptive to the family, and it can continue with breastfeeding, improve bonding, but it depends on the quality of the device, which I'm assuming there's huge variability, and the ability of the family to appropriately use it.
Correct. And so if you read between the lines here, really what we're trying to make sure is that there wouldn't be a baby with significant hemolysis who'd be on home phototherapy without somebody trained watching them and being able to check another measurement sooner and also increase the level of care.
I read that between the lines. I think that's great. And now here's one that happens a lot to us in the hospital, where a family will come in and they'll be breastfeeding jaundice, and we take great care to explain to the mothers who are nursing the child that this is very normal. Your milk will come in. This is just a slight dehydration. Happens to a lot of babies. And there's always been a debate of whether or not we should use formula or not for a short period of time. And some people really are on the side of get a lactation consultant, feed through it, IV fluids if you need to, but don't use formula for lots of reasons, including nipple confusion, etc. But the guidelines come out and say, which I'm happy they did, that breastfeeding and breast milk has many benefits, but brief use of formula might lead to a more rapid decline in total serum bili concentrations and reduce the risk of readmission for phototherapy.
Yeah, I think a lot of this is in how we say it and how we do it. And so if insufficient feeding is the major underlying cause of the jaundice, then feeding should be used as a medical treatment until the breastfeeding can improve. So I'll often present this to families as we need to give your baby some kind of milk for the next day, 1 or 2 days, until we can help you get your milk in and get the baby feeding. And that the goal is to get to exclusive breastfeeding. But in the meantime, we need to do something else. Sometimes if we can get the mother expressing, some of the supplementation can be done with the mother's own milk. But I think really explicitly saying that this is an important medical intervention and going back to what the long-term goal is a lot of what we need to do to maintain the breastfeeding and treat the jaundice.
It's helpful to have these conversations, right? Because I tell families something similar, but then I typically will discharge them on formula and then say follow up with your PCP in a couple of days, and they'll wean you off of the formula or stop it completely if everything is going well. Whereas you do just a couple of days, which I think it depends on the family and situation and the mother and if the milk is in, but both could be right. As long as it's a temporary thing to get the mother back exclusively breastfeeding, if that is what they want.
Mm-hmm. The other thing I'd say about formula is that there is evidence that if we're going to supplement with formula for hyperbilirubinemia, that hydrolysate formula will actually lower the serum bilirubin more rapidly than standard cow milk formula will.
Really?
Yes.
I did not know that. That's fascinating. So, okay, the hydrolysate will go quicker than the other one.
It'll go quicker, yeah.
Wow.
There's a in standard cow milk formula. There's an intestinal reuptake inhibitor that's not present in the hydrolysate formula.
Absolutely fascinating. Thank you. That's great. I didn't know that. I'm going to incorporate that. Now, and this other point here, I get into with discussions with nurses a lot on the floors in terms of interrupting phototherapy. How much is okay? What's too much? And you flat out say, interrupting intensive phototherapy for breastfeeding does not impact the overall effectiveness of phototherapy if it is otherwise appropriately used, and the interruptions should be minimized, which is very helpful. It's what we always tell our nurses. It's nice to have it in black and white supporting us.
It is, and there are some hospitals where if you are rooming in that mom and baby for breastfeeding, and you really do want to keep the lights on, there's nothing wrong with putting an overhead light over the baby while the baby's breastfeeding. We give the mom some protective glasses, and then you can keep the light on and they can feed at the same time.
Oh, I've never thought of that. Well, that's great. Now, you say the use of IV fluids is not recommended unless there's evidence of dehydration that cannot be corrected enterally, or if the total serum bili exceeds the escalation of care threshold. Mm-hmm. I found that surprising because, a lot of times by the time the child comes up to me, let's say, they have been in the ER perhaps, and they have gotten a bolus of fluid to help rehydrate them for breastfeeding jaundice, because a lot of times, like we've said, that is a hydration issue as well, and we think that'll help. But this is saying, you could just feed through it.
Yeah, it's because the feeding is more effective. So the more milk that you get into the intestine, the more bilirubin removal you're going to have in the stool. and the less enterohepatic reuptake and recirculation you're going to have. So getting as much of the rehydration enteral is going to lower the bilirubin faster.
Fascinating. And then for prolonged indirect hyperbilirubinemia, infants with 7 days or older and with a persistently elevated total serum bili within 2 milligrams per deciliter of the phototherapy threshold may have prolonged indirect hyperbilirubinemia, and they recommend confirming this with a fractionated bilirubin measure, and that most of these infants will have breast milk jaundice, but other causes like we've talked about, hemolytic disease, hypothyroidism, extravascular blood, pyloric stenosis with Gilbert syndrome, and Crigler-Najjar syndrome. And then limited studies suggest that prolonged exposure to indirect hyperbilirubinemia might be associated with an increased risk of neurotoxicity, although other studies have not found the association, and you can consider treatment with home phototherapy.
Yes.
Which I loved all the way.
These are rare. So, we would know that these would be unusual findings. But there are some babies with breast milk jaundice that can remain quite high for quite a while.
All right, moving on to KAS 12. This one, I wrote no help and how often. I'm going to read what I mean by this. For hospitalized infants, total serum bili should be measured within 12 hours after starting phototherapy. The timing of the initial total serum bili measure after starting phototherapy and the frequency of total serum bili monitoring during phototherapy should be guided by the case of the child, the presence of the age of the child, the presence of the hyperbilirubin neurotoxicity risk factors, the total serum bili concentration, and the total serum bili trajectory. And they also reviewed that the total cutaneous bilirubin measures on skin exposure to phototherapy tends to underestimate the total serum bili values. I was hoping for more guidance, specific how often, Q4, Q6, because that's always, and anywhere I've been, that's always been the issue, is some people will say every 4 hours, some will say every 6, some will say every 8, every 12. Here, I guess you're saying there's no evidence one way or another, so do what's best for the patient in front of you. Is that fair?
So I think what we're saying is that it depends on the cause and the level. So if you have a baby who has an early hemolytic jaundice and they're over the treatment threshold, say before 24 hours, you're probably going to measure that bilirubin again in about 4 hours because you're not sure if that baby needs to go to the NICU for a higher level of care and maybe an exchange transfusion. However, if you're seeing a fully term baby who is out at 4 days, 5 days of age, and they're just over that treatment threshold of 22, and they're not DAT positive, and their feeding's kind of poking along okay, that baby is probably not going to go that much higher anyway, whether or not you treat them with phototherapy. And so you can wait a little bit longer on that baby if they're coming back into the hospital at day 4, day 5. You can probably wait 12 hours.
That makes a lot of sense. I appreciate that. I appreciate you explaining that. And now the next key action statement for infants receiving home phototherapy, the total serum bili should be measured daily, and infants should be admitted for inpatient phototherapy if the total serum bili increases and the difference between the total serum bili and the phototherapy threshold narrows, or the total serum bili is less than or within 1 milligram per deciliter above the phototherapy threshold. So it's really nice guidance for people who are doing this at home when a patient should come in. And sometimes we get those calls, rarely. Most of our PCPs here know exactly how to do this. Most do. But it's nice to have this in black and white. So that's very helpful.
Yeah, we talked about that a lot on the committee. In my region, we don't do a lot of home phototherapy just because of equipment and rural nature and distances. But there are a lot of places where more home phototherapy is done, and people wanted clear guidance like this.
Now, the next key action statement for infants requiring phototherapy, you should measure the hemoglobin, hematocrit, and CBC to assess for the presence of anemia and to provide a baseline in case anemia develops. And they want you to get a DAT in infants whose mother had a positive antibody screen or whose mother is blood group O, regardless of Rh status, or whose mother is Rh negative. And G6PD activity should be measured in any infant with jaundice of unknown cause whose total serum bili increases despite intensive phototherapy, or whose total serum bili increases suddenly or increases after initial decline, or who requires an escalation of care. So key action KS14 really kind of gives us what you should order and when you should order it and when you should be worried.
And it's really pointing you to be investigating for the presence of hemolysis, the outcome of significant hemolysis, which in addition to hyperbilirubinemia is, of course, anemia. Sometimes there's enough hemolysis with ABO incompatibility that you might even need a simple packed red cell transfusion just because of the anemia associated with it. And then, of course, pointing us to be considering G6PD deficiency in those unusual cases.
And then here we're reviewing in an infant less than 24 hours old with a total serum bili concentration above the phototherapy threshold, likely has a hemolytic disease. And they talk about here measurement of end-tidal CO2, if available, may help in identifying hemolysis. Identifying whether there is G6PD or hereditary spherocytosis or another red cell membrane defect can help identify infants at risk for recurrent hemolysis and also provide information to families about potential risks for future pregnancies. And then they recommend, if you're seeing this, getting a neonatologist or hematologist or both consulted for guidance can be helpful.
Yes, we're back to the be on the lookout for hemolysis.
Yeah. Now, stopping phototherapy is the next section. Rebound hyperbili, and this is always a discussion in a hospital. I think a lot of places, each tending does rebound a little bit differently. Here you define it, which I like. Defined as a total serum bili concentration that reaches phototherapy threshold for the infant's age within 72 to 96 hours of stopping phototherapy. That was a very broad timeline. So it's a huge amount of time, 3 to 4 days. And infants who get phototherapy during their birth hospitalization are more likely to experience this than a readmission. I don't know. It just seemed like a very broad time, but maybe I'm thinking more about rebound hyperbili again, I'm always thinking in the hospital after we stop phototherapy, which you get into next. So it's probably more me than anything else.
I think what that's pointing to, though, is, if you have phototherapy during the birth hospitalization, those are cases where hemolysis is more likely to be your underlying cause. And so if that's the underlying cause and the hemolysis continues, you're going to be more likely to end up over the phototherapy threshold a second time.
Oh, that makes sense. Okay. And if maybe the underlying cause wasn't identified, this is another opportunity to think about it. And then you have risk factors for rebound hyperbili are younger postnatal age, less than 48 hours at the start of phototherapy, like we just said, hemolytic disease, gestational age less than 38 weeks, higher total serum bili at the time of discharging the patient from phototherapy. And the studies for overall risk vary from 4.6% to 24% for rebound hyperbili. So that's a huge range.
It is. The general recommendation, though, is that most babies who get phototherapy in the hospital, either the birth hospitalization or if they are admitted again from the outpatient setting, there's only very few of them that need a bilirubin checked before they go home. So essentially, if you discontinue phototherapy, unless the baby is still under 48 hours of age, you need not get another bilirubin off of lights before they go home.
Fascinating. Okay. That's very helpful. Very, very helpful. Now, the next key action statement is when stopping phototherapy is an option when the total serum bili has decreased by at least 2 milligrams per deciliter below the hour-specific threshold at the initiation of phototherapy. And a longer period of phototherapy is an option if there are risk factors for rebound hyperbilirubinemia.
Right. So this makes sense. So if you, again, have an older baby who's further out on that flat part of the treatment nomogram, and they're fully term, they're 38 weeks and over, being 2 under the line is probably completely sufficient for discharging them and having them be followed up the following day. However, the other babies who are at higher risks for rebound and also potentially have hemolysis, you might want to drive the bilirubin lower, so more than 2 below the hour-specific treatment threshold. So if you have a 35-week gestation age baby with hemolysis, maybe you want to be closer to 5 below before you discontinue phototherapy.
That's interesting. So the way I'm reading these, Alison, if I have a fully termed 38, 39-week infant here with indirect hyperbilirubinemia on day 2 or 3, and had nothing less than 24 hours after birth, and have no risk factors for either rebound or severe hyperbilirubinemia, like the albumin, et cetera, we talked about. Once that gets below the threshold, I am not going to repeat it again because I've probably fixed the feeding issue. Likely that's what it was. And then I'm going to send the child home. There's no need to keep them later, et cetera. And you're agreeing to that, right?
Yeah. And then we'll get to a follow-up chart that is pretty specific about the different categories of babies and when they need follow-up. So there's the follow-up recommendations for after phototherapy. But yeah, 1 to 2 days later would be fine for a baby like you just described, Tony. And then there's a whole other set of recommendations for how to follow up babies after the birth hospitalization.
All right. So let's power through. This is great. So then the key action statement 16, and here, this is on page 11 for those who want to read it on their own. This was very helpful. So first, the repeat Billy measurement after phototherapy is based on the risk of rebound of hyperbili. So that's what we're just talking about. Infants who get phototherapy during the birth hospitalization and receive phototherapy before 48 hours of life, had a positive DAT, or had a known or suspected hemolytic disease, should have total serum Billy measured 6 to 12 hours after phototherapy. All other infants who get phototherapy during birth hospitalization should have bilirubin measured the day after. And this is, so on page 11, it goes through point by point when you should have people remeasured. So infants, go ahead. Sorry.
No, that's exactly what it does.
And it's fascinating. I mean, all other infants who exceeded phototherapy threshold during the birth hospitalization should have bilirubin measured the day after phototherapy stops. Infants who got phototherapy during the birth hospitalization and who were later readmitted for exceeding the phototherapy threshold should have bilirubin measured the day after phototherapy stops. Infants readmitted because they exceeded phototherapy threshold following discharge but did not get phototherapy during the birth hospitalization, and infants who got some home phototherapy that needed to have that escalated should have bilirubin measured 1 to 2 days after phototherapy stops, or clinical follow-up 1 to 2 days after phototherapy to determine whether bilirubin should be measured. And I had not seen a table like that or a section like that kind of going through it at all in anywhere else, and I really loved that.
Yeah, we heard from the pediatric community that guidelines on when to stop phototherapy and when to follow up after stopping were something that people really wanted.
Yeah. I mean, that's wonderful. The next key action statement is 17, and we begin to get into escalation of care. When an escalation of care, and I'll read it. So care should be escalated when infants' total serum Billy reaches or exceeds the escalation of care threshold, which is a whole nother figure. Now, this is hard to do in a podcast format, but this is figure 5 or 6. Here's how I'm going to explain it for you listening. Figure 5 is an exchange transfusion threshold table, which in structure is a graph that looks like the table we're all used to starting phototherapy, but it's an exchange transfusion threshold figure or graph. It's by gestational age for infants, and for figure 5, it's infants with no recognized hyperbilirubinemia neurotoxicity risk factors other than gestational age. And these are the thresholds, again, are based on expert opinion as well. Now, for just to drive this point home as much as possible, the hyperbilirubinemia neurotoxicity risk factors, again, albumin less than 3 grams per deciliter, isoimmune hemolytic disease, glucose 6-phosphate dehydrogenase deficiency or other hemolytic disease, sepsis, or any significant clinical instability in the previous 24 hours. Now, figure 6 is similar to figure 5 in the structure, the type of graph it is, but it's an exchange transfusion threshold chart for infants whose total serum Billy is increasing despite phototherapy, or infants with at least one recognized hyperbilirubinemia neurotoxicity risk factors. And it does remind us that initiating escalation of care is a medical emergency. And the escalation care period starts from the time the infant's total serum Billy results first mandate starting escalation of care and ends when the total serum Billy is below the escalation of care threshold. And NICU management is ideal. And if your institution can't do emergent exchange transfusion, you should then consider transferring this patient to one that can. That was an important key action statement. Do you think I did a nice job?
Yes, it's a new term. We didn't use that term, escalation of care, before this new guideline. So yes, of course, we had exchange transfusion thresholds, but really what we want to do is identify babies who need other types of escalation of care so that they do not exceed the exchange threshold. And we need to get them to the location of care and also get things like blood products ready ahead of time so that if they exceed the threshold or if they develop acute neurotoxicity signs, that we would be ready to go with an exchange transfusion. So while figure 5 shows the new exchange transfusion nomogram, figure 4, right before it, is a flow chart regarding escalation of care. And the first question it asks you, if your serum bilirubin is over that escalation of care, which again is 2 below the exchange level, the very first question is, are you at an appropriate location for the exchange transfusion? And if you're not, you need to get on the phone with the nearest neonatal center quickly, get them to help you with management, and then really increase your intensive phototherapy and your hydration, and start getting labs if possible as you get them on the way to where they need to be. And even if you are in a setting where you can do an exchange transfusion, it gives recommendations for increased hydration, increased intensity of phototherapy, increasing frequency of monitoring. Again, so hopefully to avoid the exchange transfusion, but to be ready to do it if needed.
And this is great because, we are partnering this podcast episode with our newborn hospitalist subcommittee through the American Academy of Pediatrics section on hospital medicine. And this is just fantastic. So this is helping us figure out when a patient needs to be moved to a facility that has a higher level of care. This is great. All right, key action statement 18. We're hitting the home stretch. Everyone listening, you're hanging in there. Thank you for hanging in there. For infants requiring escalation of care, blood should be sent stat for total and direct reacting serum bilirubin, the CBC, albumin, serum chemistries, and a type and cross match. And that's a grade X recommendation.
Yes, these are basically the things you'd need for the exchange transfusion. And then, of course, getting the albumin, because that would put you on a different nomogram in terms of the threshold for exchange.
That makes sense. And then for 19, infants requiring escalation of care should get IV hydration, and we talked about that earlier. Emergent intensive phototherapy. Consult a neonatologist about urgent transfer to NICU. We just talked about this. Can confirm that can perform exchange transfusion. We'll go right into 20 since we just talked about this. Total serum bili should be measured at least every 2 hours from the start of escalation of care period until the escalation of care period ends. Once the total serum bili is lower than the escalation of care threshold, management should proceed according to the section C. So that's helpful. Should proceed according to the section C.
Then you're just back to your regular phototherapy monitoring. If you manage to get the bilirubin back down and the infant remains neurologically normal.
Now, the next couple, I didn't know at all. IVIG, intravenous immune globulin, over 2 hours may be provided to infants with isoimmune hemolytic disease, a positive DAT, whose total serum bili reaches or exceeds escalation of care threshold. This dose can be repeated in 12 hours. And this occurs in our ICU and in our NICU, and I'm not involved.
This is
really
more
nice.
of a neonatology issue, but if you have REH or ABO incompatibility, IVIG has been shown in some cases to be able to help avoid an exchange transfusion.
And then, speaking of exchange transfusions, KS22, an urgent exchange transfusion should be performed for infants with signs of intermediate or advanced stages of acute bilirubin encephalopathy. So anyone with early signs should get an urgent exchange transfusion.
That's right. So not all cases of acute bilirubin encephalopathy go on to chronic bilirubin encephalopathy if they are noted quickly and treated with exchange.
And so the next one, KS23, an urgent exchange transfusion should be performed for infants if the total serum bili is at or above the exchange transfusion threshold. If while preparing for the exchange transfusion, but before starting it, the total serum bili gets below the exchange transfusion threshold, and the infant does not show signs of intermediate or advanced stages of acute bilirubin encephalopathy, then you can defer while you continue your intensive phototherapy and still follow the total serum bilis every 2 hours until it gets below the escalation of care threshold.
That's right, because sometimes just the getting everything you need from the blood bank and getting all your equipment together, your phototherapy might have been successful in those few hours that it took you to do that.
Now, the table you're talking about, because we've gone through all the key, unless I missed something, the next parts are the post-discharge follow-up. The table you're talking about for follow-up is figure 7. Am I correct?
That's right.
And this is great because it talks about phototherapy. Pronouncing all this stuff has been a real challenge. Phototherapy threshold minus total cutaneous bili or total serum bili, and then discharge recommendations. And for those those at home, I'm not going to read it to you, but this is, unless Alison, there's something you want to point out, but I think this is a great thing for people to have in their back pocket to know is available.
I think so. The other thing I'd point out about figure 7 is, you've noticed over this podcast, we haven't talked about the risk nomogram, otherwise known as the Butani nomogram. And that's because that nomogram is no longer featured in the new bilirubin guideline. There were a number of issues with it, including some confusion between the risk nomogram and the treatment nomogram. And also because of the risk nomogram being derived from a non-representative population and also one that didn't include any DAT positive babies. So it also wasn't validated in a separate population. So to avoid the confusion and potentially working with data in a nomogram that wasn't derived in a way that everybody thought was most appropriate, we came up with figure 7 instead, which basically says the way that you should be assessing risk at the time of discharge is by taking the baby's phototherapy, taking the baby's bilirubin level, subtracting it from the phototherapy threshold, the hour-specific one, and then making the determination of when to return for follow-up based on how far below that threshold you are and on how old the baby is at the time of discharge.
Interesting. So I'm glad you guys took it out then. That makes a lot of sense. Well, Alison, that is everything I had, all of my notes in my yellow legal pad here. But I always ask our guests, is there anything we did not talk about that you felt we should have or you wanted to?
No, we covered all the things that I usually talk about when I give grand rounds on this topic, but I was happy to be able to come today to the podcast. Thanks for inviting me, Tony.
And thank you so much for coming. And I do want to give a special thanks to the Newborn Hospitalist Subcommittee in the Section on Hospital Medicine Leadership, because they helped organize this and they emailed you. And without them, this wouldn't have happened. So I do want to thank them. But Alison, thank you so much for being on the show today. Really, I appreciate your time.
Great. It was really fun to be here.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at Tony, Tony.Tarchichi, Tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.